I lost my audio for a while. I'm Larry Boris. This is the National Association of Worksite Health Centers monthly first run Monday roundtable. We're pleased to have Dr. Bruce Sherman from Place Western and Northern Carolina Business Group on Health join us. Next slide, Bruce, please.
Sorry.
Can you change the next slide, please?
Yeah.
Okay. So the roundtable format today is we're going to ask everyone to just introduce yourself, give your name and your title and general responsibilities. Then I'll turn it over to Bruce, who'll cover the topic of today, which is on health outcomes and equity. And then we'll ask everyone for their own experiences, advice, questions, etc., relating to this topic. We want this to be a networking opportunity, give you a chance to learn and meet some other people with that. So I'm just going to go around the table as I have your name on my computer and just ask you to unmute and give your, again, name, title, and organization, a little bit what you do. I do have someone who's calling in. So all I have is a 949 number. If you would tell me who that is and identify yourself. You can't? All right. Anne Marie, would you introduce yourself, please?
Absolutely. Hi, everybody. My name is Anne Marie Rutger, and I'm with Novant Health Employer Solutions. And I serve as a health and wellness partner for the team. Basically, my responsibilities are to get to know each of our clients that we support within our business community, whether it's our on-site wellness clients or our clients that we work with seasonally or through maybe flu shot season or biometric screenings or corporate physicals. So I connect with those clients and I work with them to decide best outcomes to work on making sure that they have all the services available that they need to support their employees. I develop a little bit of their, I'm sorry.
Where are you located?
I work throughout the Novant Health footprint. So typically I work primarily in the Winston-Salem market as well as the Charlotte market, but really throughout the entire footprint, which includes the coastal area as well.
Thank you, Anne Marie. Cindy Jo, would you introduce yourself, please?
Sure. Hi, I'm Cindy Jo Manette. I'm with Franciscan and I'm in sales and marketing. So I work with the clinics where we do the occupational health services, anything from Department of Transportation physicals, drug screens to non-DOT physicals and drug screens, new hire physicals. And then we also have a employer clinic program. Then I work with our clients to help them make the most of that program.
Great,
and I'm in the southern Indianapolis area.
Great, thanks very much. Betsy Nola Kirby, Betsy, introduce yourself, please.
Hi, sorry, I had a little problem with the Zoom link, so that's why I'm late. Betsy Noda Kirby. I am the Vice President of National Health Management Consulting at Marsh McLennan Agency. I work nationally with all of our health and well-being consultants, and I also support our worksite clinic consulting practice as well. So happy to be here. Thank you.
Thank you. Cindy Jo, introduce yourself, please.
Hi, thanks. I've already gone.
Oh, sorry.
That's okay.
All right. Deanna Hahn. Deanna, introduce yourself, please.
Yeah, hi, Deanna Hahn. I'm with SSM Health at Work. I'm a director in our Wisconsin market for our occupational health services, and then also work closely with our clients on the on-site, near-site clinic programs.
Thank you. Laura Spalding. Laura, introduce yourself, please.
Hi, good morning. Lara Spalding. I am in Fort Worth, Texas, but I work nationally with Premise Health to support our occupational health clients and over 400 occupational health sites. Thank you.
Thank you. Melanie Small. Melanie, introduce yourself, please.
Hello, sorry, I'm also having some technical difficulties here. Excuse me, I'm Melanie Small. I work for Intermed. We are located in Maine. We are a primary care practice that has operates a couple of very large on-site clinics for a couple of local clients.
Great, thank you. Michael Kaufman. Michael, introduce yourself, please.
Yeah, hi, good day, everybody. Dr. Michael Kaufman here. I'm with Eli Lilly and Company, based out of Indianapolis, Indiana. And I have responsibility for keeping 45,000 employees around the world healthy through our network of 13 on-site employee health clinics around the world.
Great, thank you. Tara Baxter Klein. Tara, introduce yourself, please.
Hi, I'm Tara. I am the clinical supervisor of Beacon Health Systems worksite clinics. We're located in northern Indiana by Notre Dame. Yeah.
Great, thank you. And finally, Todd Hatton. Todd, introduce yourself, if you would.
Hi, good morning, everyone. Todd Hatton. I'm the Chief Revenue Officer for AS Medications. I'm located in Southern California, but we have a national footprint. We bring pharmacy solutions, on-site dispensing, mail order, and other mostly carve-out programs to employers and employer health groups, and then also work in urgent cares, workers' comp clinics, and with Medicare and Medicare Advantage to bring alternative med distribution programs.
Great, thank you. Did I miss anybody? If so, please introduce yourself. And if not, Bruce, I'll turn it over to you.
Okay, thank you, Larry. And I think we can just jump right ahead here. By way of background, my connection to worksite clinics was back in the day, which just means that I am older than most, if not all of you. Worked with whole health management starting in 1998. Left there in 2003 when I was medical director. And of course, for those of you that don't know, Whole Health was part of the acquisition by Walgreens, which ultimately turned into to Premise Health. And many of the folks with whom I used to work are still at Premise Health. But we have, it was a fabulous jumping off point for me for a career that has spanned corporate medical director roles at Goodyear, Whirlpool, Walmart, working with a private exchange offering, and throughout that time doing research regarding workforce health and well-being. And you'll see a lot of that come through in the slides that I have to share. I'm going to go reasonably quickly through the slides, but I also want to make sure we have time for discussion. I think there's a lot of interesting data that I'll have to share. For the last 10 years, I've been focused on workforce health equity. And I think worksite clinics are a unique environment where clinic operators can overcome some of the traditional barriers that we see to inequitable healthcare practices. So you'll definitely get a sense of that from my presentation. Is there anybody that hasn't seen this slide previously? Feel free to come off mute and share your sentiments. This is just going to give me a sense of where everybody is with respect to their understanding of the whole health equity versus equality issue. And just as an editorial aside, I'll be talking a lot about employee health benefits, which still for the preponderance of employers are equal, but not equitable. One size fits all plan designs with no considerations for low-wage workers. So with that, I want to just sort of back up a little bit and talk some about social determinants of health, health disparities and health inequities. I think most, if not all of us, are very focused on social determinants of health as a driver of health inequities. And but that's only part of the issue. When we think about disparities in care, we have to think about a number of other factors, and these lead to inequities as well. And you'll notice that I've got listed here a whole series of demographic attributes, as well as social determinants of health, but also bias, discrimination, and medical mistrust. And what we're learning in our research is that these are particularly important for individuals. And we're, I think, only beginning to address the tip of the iceberg, or understand the tip of the iceberg here when it comes to health equity and equitable health outcomes. So when we think about health inequities broadly, the way I'm going to define that is that there are individuals who are unable to achieve the highest level of health. And that's an issue or a result of addressing or a lack of or ineffective attention to unjust or unfair health disparities. And we get to health equity when we have addressed the broader scope of those issues. So if we can fix all of the issues in the middle of this center column, or at least acknowledge their existence, that's when I think we end up with more equitable health outcomes. Want to just share a little bit of a foundation for why we are seeing health inequities, especially in the context of social determinants of health. And for those of you that haven't read this book, it was absolutely paradigm changing for me. And it's about the significance of scarcity. It was written by a behavioral psychologist and a health economist. And what we learn from this book is that people who have scarcity in their lives, whether it's time, love, money, they focus on those priorities to the exclusion of other issues or opportunities in their lives. And I'll show you examples of these in healthcare claims analyses. Bandwidth tax is essentially a result of tunneling, where people just don't see opportunities that are available to themselves. So, take a woman who is struggling to make ends meet, has a child who's not doing well in school. She's a single mom and worried about paying next month's rent. We have a conversation with her talking about her cholesterol. That's just not a high priority for her. She's got many other things to think about. So even if maybe there's a copay waiver for her medications, she's just not able to find the time, the energy, the motivation to more meaningfully manage her cholesterol, because she's got much greater priorities of concern. And then Slack is essentially the other end of the spectrum. And I'll show you a really interesting example of this. When people don't have scarcity, how do they think about their own health and well-being? Larry, is it permissible for me to ask folks to come off mute if they have questions? Because really like to have this be more of a dialogue, if we can. So I'm assuming that that's okay, and please feel free to come off mute. I can't see everybody's pictures, so just feel free to shout out, and I would be delighted to engage in more conversation with you. So thinking about Maslow's hierarchy, which is what I think this sort of concept of scarcity is most well aligned, is if you want to have a high performing employee, you've got to meet basic needs. And that's where the foundational issues of unmet social needs or social determinants of health can be found. If people are distracted, we talk about presenteeism. We've known about that in relation to financial stress for 25 years. And it's still, for many people, still a big concern. So here's where it gets interesting. And I think the marketplace is very much focused on social determinants of health. But what we've learned, and this is one example, and I'll show you at least one more, is that even when we adjust for socioeconomic status, there are still differences in the way that healthcare is being delivered, particularly in this setting for pregnant Black women. And these numbers are really pretty sobering, so that we can't just blame this all on socioeconomic status. We know, for example, the stories of a few folks that have had healthcare issues related to pregnancy, it's really quite striking to look at these numbers and appreciate that there may be other issues at play. And this is where I really want to focus a good bit of attention, because I think the worksite clinic is just a great place to address issues. And what we're dealing with here, in all likelihood, is a combination of two things. One is implicit bias, and the other is medical mistrust. Said simply, if you are a Black individual or a person of color who has a healthcare provider that you feel is judging you, are you going to trust that person? And I think the answer for many people is no. So when we look again at that Maslow's hierarchy pyramid, what we're seeing is that we've got to put systemic racism and inequity at the bottom, below social determinants of health, because people aren't even going to access the healthcare system if they're feeling that it's not working in their best interest. And not to get into issues of medical mistrust, but the Tuskegee experiment with syphilis, other experiences that people have had with respect to inequitable care or perceptions of racism in care delivery. Those are major sources of concern. I'm going to skip that slide and just talk a little bit about health inequities. And I've been working with the Pittsburgh Business Group on Health on a project to look at maternal health inequity. And what we found was that it's really helpful to think about this from the stakeholder perspective, and what are the root causes of health inequities. So if we think about benefits enrollees, it's a combination of a number of factors. We talked about unmet social needs, health and health benefits literacy issues, access, affordability concerns, and medical mistrust. When we think about clinicians, I wish I could say we were all perfect as clinicians and culturally humbled, but we're not. We bring our own implicit biases to the work and the care that we provide. And systemic racism, unfortunately, is alive and well, and especially if we're not looking to see what's going on, it's definitely alive and well. And we just don't appreciate how our biases are impacting the care that we're delivering. From an employer standpoint, it's amazing to me today that health inequities are still not a major focus for employers. And that if employers looked at their data, they would see where some of the issues lie. Unfortunately, with claims data, it can be really hard to figure out exactly where those or what the root causes of those inequities are. And I'll share some examples of that with you. There's something called in-group bias, and that means that we design programs and services for people like us. So we're not necessarily thinking about how appropriate educational programming is or communications are. We're not thinking about health as an investment in the workforce. We're thinking, by and large, about it as a cost containment effort. And it's remarkable to me to think that in 25 plus years of doing this, we're still focused on ROI, not on value of investment. And one of the other things, and I think it's a huge opportunity for worksite clinic vendors is to take accountability for health inequities and be proactive, because I think there is a big opportunity from a marketing standpoint, in a business development standpoint, to address some of those health inequities and also take accountability for them. And lastly, health plans, not all of them get the kind of data that they need to look at race, and we'll talk more about the impact of wage in just a few minutes. And they also haven't, to this point, addressed the issue and the needs for culturally humble clinicians who can provide the kind of care that individuals need. And this is, to me, an area where we still have a lot of work to do. We tend, I think, as a healthcare industry, to focus more on our systems and processes, and too often blame the victims, the patients, for reasons why they're not compliant with their own healthcare. So let's jump into the data. Actually, you know what, before we start that, let me just pause for a second and just see if how people feel about this approach, and does it resonate for you? Would love to hear comments or feedback. Don't be shy. Please.
I'll jump in and just say that this resonates very much with me. At one of our clients, we asked the payer to split out the claims by hourly versus salaried employees, and it was very enlightening. It was very, probably what you're just going to share with us in a minute here, but we found that it was really helpful for us. And with the medical mistrust you talk about, we hear about that every day in our clinic from our clinicians who have developed trusting relationships with the employees, rather than one of distrust or at least suspicion. So that's all
Thank you for sharing that, and I appreciate it, and it's wonderful to hear that that there's a focus there. What I've been hearing from folks, and this is all anecdotal, is that for many organizations there's been a big focus on social determinants, but again, we're focusing on what we think patients need, not what their issues are, what the barriers to care are. And we probably would do better asking them what stands between them and taking better care of their health. We don't have enough time to get into that in great detail, but we'll talk a little bit more about it.
Bruce,
Yeah.
it's Betsy. So when you did this study of low wage earners, what did you did those individuals have commercial insurance through their employer, or were these individuals those that might be on Medicaid or swinging between Medicaid and, you know, the health exchange? And the reason I'm asking is because obviously in my role right now, I work with employer groups and they have group benefits, but my previous professional experience weighed heavily with working with other populations like the Medicaid population and the health exchange. And, you know, we saw it very clearly in the data, no question about it. Medicaid recipients use the ER for routine care because, you know, of many reasons, which I'm sure this entire group is well aware of. So I was just curious, you know, when the study was conducted, if it's definitely all employer sponsored, or if there's any element of individuals, you know, flipping back and forth between managed Medicaid.
Certainly, Betsy, and appreciate the question. And I guess we can jump right into to talk about this slide. This was only, the study only included employees, not dependents, who were enrolled during a 12-month period in a private exchange offering that had a big focus on high deductible health plans. So we did not have race data at the time. What we were able to use was wage data. And we split out the data in quartiles. It's about 45,000 individuals across, I think it was 7 different companies. And for those of you that are astute, I said quartiles, but you'll notice 5 sets of data. The lowest one we split in half because we wanted to see whether there were even greater differences at the lowest end of the wage spectrum. And what you notice, if we look at the left side first, that low-wage workers use substantially more or go to the emergency department substantially more often for what we would consider, also, and we didn't include this in the data, low acuity conditions. They have substantially higher number of inpatient admissions as well as avoidable admissions, which are defined as those which could be managed more, which could result in an avoided hospitalization if they were managed proactively in a primary care setting. You'll notice on the graph on the right that preventive care services are used about half as often among the lowest wage workers. And this study is rigorously controlled for a whole array of sociodemographic factors, chronic conditions, including both physical health and psychiatric conditions. So we feel that this is a really an appropriate statistical or comprehensive statistical analysis. So really quite striking. And the question I'd pose back to you to think about is, why is it that people at the low end of the wage spectrum are more likely to go to the emergency department than get their preventive care? Laura, I see you've got your hand up.
Yeah, hi, Bruce. I was wondering if perhaps it might be that they have to take time off to leave work and attend those preventive appointments.
Yep, absolutely. That could be one of the reasons. When I was at Walmart, we learned that people that were enrolled in the high deductible health plan also appreciated that they could go to the emergency department a few times during the year, and because that's the one place they can go where they don't have to pay anything before they receive care, thanks to EMTALA. And as a consequence, they then basically ignore the debt, which gets written off. And as a result, they've satisfied their deductible. And we heard people talk about this. So it's fascinating to me how people are motivated when we really understand what they're thinking is how they take advantage of the system for their unique needs. But you're absolutely right. It could be that could be a reason, having to work and leaving work and not being paid if they're hourly workers to get care. That may also be the reason why they're avoiding screening services. And one of the other reasons there, interestingly, is we heard it when I was at Walmart, is I feel fine. If I go get a screening, I'm probably going to have to pay for part of it, even though they say it's free. And if they find something, then I'm going to have to pay even more. And I feel fine, so I'm just not going to worry about it right now. So when you talk to people, you find out so much more about what's going on in their lives to influence how they access healthcare. And we'll tie this back to worksite clinics in just a second. What was and I shared with you that last study we didn't have race data for. This one was a look at an even larger population. This was about just over 2 million people, looking at the use of specialty drugs. And I think it was serendipity for us that we chose race, ethnicity, and wage to look at when we were evaluating the data. We knew wage was already important. We didn't know what the impact of race was going to do. So what this shows is the use of specialty medication for people with autoimmune disorders in a calendar year, divided again by quartiles, with the lowest quartile being split in half. But then we also split out the data by race or ethnicity. And what you see is at high wage levels, there really isn't much difference between the groups. But as wage falls, we notice that there is a substantial decline in the use of specialty biologics by people of color. The all other data is a sort of composite of a whole host of other smaller racial ethnic subpopulations, including Asian, Native American, multiracial groups were probably the three big ones. But this was sobering to us. Part of the reason it was sobering was we could only get race ethnicity data for about a third of the population that we would have liked to have had. So we would have wished we had even more bigger population sizes. But it certainly indicates that there's something going on here. And whether it's medical mistrust, whether it's implicit bias, why is it that individuals in the white category have higher medication, especially medication use, compared to people in other races at lower wage categories? Is it that that people in the high wage categories are much more comfortable with accessing care and don't have better relationships with their providers, so that they don't feel like they are, there's no issue of medical mistrust? But that's not the case for the folks at the lower end of the wage spectrum, especially among people of color. We just don't know. And this is I think a great opportunity to learn more about what's happening. Thoughts, questions? I'll keep going. One of the examples that I wanted to share with you, so we talked about scarcity and how that may have impacted motivations to get preventive care and use the emergency department. Here's a wonderful example of Slack. And what you see is the more people earn, seemingly other than that lowest wage category, the more they're spending on healthcare. And when we looked at the data, and if you recall that earlier slide, the high wage group had the lowest rates of hospitalization, the lowest rates of emergency department use. So what do you think's driving their healthcare costs? Well, in the interest of time, I will tell you, it's my toe hurts, I'm going to go to the doctor. My shoulder's sore, I'm going to go to the doctor. I need to get physical therapy for my elbow. Discretionary use of ambulatory care services was way, way higher in the high wage group compared to the lower wage categories. And that's what was driving their healthcare costs even higher. So, and if you look at the numbers, you can't really see it across the slide, but statistically not significantly different than the lowest wage group, but the trend was definitely higher in that highest wage category. So a bit of a surprise to us, and good understanding of how Slack can impact healthcare utilization and overall costs. This is one of the slides that I really wanted to spend a few minutes of time talking about. This was a study using the same data set of the 45,000 people, all with anywhere between a $200 to $600 financial incentive to complete the health risk assessment. And when we looked by wage, we saw that the numbers dropped significantly in terms of participation with HRA and biometric screening. for the subpopulation. So here's another example of scarcity. You can get $200 to $600 for completing this, but lower wage workers aren't doing so. Why is that? Is it scarcity? Is it medical mistrust? Is it that my employer is going to get this data and they may make a hiring or a firing decision based on what they find out? So maybe it's just better that I don't share my data. What else does this do? It does one thing that to me was, or causes one important, or creates one important issue, and that is if we look at the health risk assessment data, the aggregate data are skewed toward the higher wage people. So if we're designing programs and services based on the needs of the individuals, we're going to be inclined to provide programs that are more likely to be of benefit to the program participants than the program non-participants. And to me, this is one of the issues that I think we are seeing and beginning to dig into is health promotion programs. If participation rates are primarily for among the high wage individuals, are we actually worsening health inequities or health disparities by offering these programs? Are we sort of losing track of the folks at the low end of the wage spectrum? And I think it's a real issue. We tend to focus so much more on the participants and not on what's happening with the non-participants. And what I'll share with you very quickly is we have done some other work looking at participant versus non-participant data, and the healthcare utilization patterns between the two groups are mind-boggling. So if you have an opportunity to look at claims data for an employer, look at the comparison of the people who participate in well-being program activities compared to those who don't. And I think you'll be surprised with what you find. So this isn't really a health issue. It's more than that. It's a business issue. And I think one of the things we're seeing, especially now, particularly post-COVID, is employee engagement and retention, where we see major shifts in the workforce in terms of how engaged they are with employers. And if people don't feel engaged, they are going to be looking for other jobs. And this study from 2007 on the right-hand side of the slide, that statement holds true. I believe, Betsy, that Mercer has done some work in this area more recently, like in the last 2 to 3 years, and again has affirmed this. My employer cares about my well-being is such an important driver of employee engagement and, more importantly, retention. So we've got to think about this from a business standpoint. This isn't just about health and well-being. And by the way, any of these slides or any of the references, if anybody wants, I'm happy to share. So let me keep going here. The approach that we've taken, and we're actually working on a NIOSH Total Worker Health grant right now to explore this a little more fully, is combining these 3 lines of thinking to develop programs and services that will engage everybody to improve health and well-being for everybody. So we're using evidence with employee data, demographic data, wage data, race, ethnicity data, and looking at program participation. We're using human-centered design to elicit what do people need? What aren't we providing where we have gaps? And for an organization that we're studying, who has a substantial focus on cultures of health, it's amazing how they have not really gotten the insights from the frontline workers, who are the low wage workers, to help them improve their health and well-being. And then using systems thinking to put all of this together in a way that develops or yields a more structured, data-driven, evidence-based approach that the employer can use to systematically approach improvements in health equity. So when we think about what can be done, at a high level, some examples here, I'm just going to skip ahead. But the bottom line here is thinking about health equity as a source of business value to promote employee retention and improve employee satisfaction. Tactically, there's still employers out there who feel that their legal teams are telling them, oh, we can't incorporate race, ethnicity in claims data analyses. I'm still looking for a reason why that isn't an option, other than that it is, could potentially open the employer to some vague liability, but more and more employers are doing this. Again, thinking about gathering more data from individuals, especially those who aren't using, aren't participating in surveys or aren't using worksite clinics, for example, and then establishing some accountability, as I talked about earlier. So let us talk about worksite, near-site clinics. And I think here's an opportunity for organizations to look at equitable use of on-site clinics. And my sense is that there are probably opportunities that exist. I haven't seen any data from any of the vendors published in the peer-reviewed literature about this, and would be happy to work with anyone to generate some of the data to do this. But I think there are strategic approaches that could be taken to address, to uncover issues with this and develop approaches to address them. We've seen that in clinics, as a result of trust building, that there are more equitable and more beneficial, favorable clinical outcomes with improved disease control and compliance with medications, as well as preventive care services. And then if the clinic vendors are working with the employer on more of a systematic or systems-based approach, I think the opportunities are even that much greater to enhance the overall impact of clinic service delivery, not just from a health standpoint, but also from a business value perspective. From a tactical standpoint, thinking about equitable use of clinics by socioeconomic group, by race, ethnicity, subpopulations, and then also looking among those participants at how they're doing with managing whatever conditions are being managed, or whatever health outcomes are being evaluated. Participation, for example, with vaccinations. But the key is understanding and addressing what the barriers to care are. Is there evidence of medical mistrust? Are there concerns about unmet social needs that are preventing people from accessing services? Ask people what they need. What's standing between you and taking care of your health? That's a very different question than, do you have food insecurity? If you think about it, this is a much more empowering question to ask of individuals. What's standing between you and taking better care of your health? Because it gives the person a chance to respond and tell you what's important to them. Not what's the matter with you, but what's important to you. And it's been hard to address this issue because so many people use SDOH checklists And I'll get off my soapbox on this in a second, but it's fascinating how going through a checklist is really clinician centric, not patient centric, because no list of social determinants or unmet social needs is complete. Any of the ones that are out there are missing something. If you look at surveys of those. And then lastly, look at the claims data to find evidence of health inequities in the use of community-based healthcare as opposed to what's happening in the worksite clinics, because my sense is there's a huge opportunity there to leverage the value of the clinic, especially if the outcomes in the clinic are better than what is being seen in the community. So I will wrap up with a summary slide. I've got a couple of other slides that I'll just flash with you that you'll have. But I think we've talked about health inequities in the workforce. It's not just unmet social needs. It's medical mistrust. It's personal priorities. It's implicit bias from community providers. We have stayed narrowly focused on clinical issues and not on some of these broader whole person concerns, like asking people what's important to them. If we can get at the root causes of these health inequities, not just think about unmet social needs, I think we have a chance to improve people's health much more effectively. So if we use data, we can, and along with this sort of human-centered design approach and systems-based thinking, we can come up with more meaningful and impactful solutions. But we've got to start with understanding where the issues are. And then if we can implement these kinds of programs, be mindful of looking at where business value may be derived. One of the things that we know is people who don't engage are also more likely to leave their employer. So if you can get people engaged, chances are that will likely keep them in the workplace. And employers love retention. It's critical. So with that, just a couple of other references for inclusion here. Workforce health as part of DEI. This one addressed that hot button that I just mentioned about checklist versus building trust. And then self-promotion. This is a nonprofit organization. I have spent hours on this, will not receive 1 cent from or any revenue from the sale of this book, but it's a wonderful guide for employers and it's available at the website. And close with this slide with my email. If you want to reach out to me for more information, happy to share. And if anybody wants to be involved in some more rigorous research activities with the data that they have, please reach out. Thank you. I will stop there and stop sharing too. Larry, back to you. We got you on mute, Larry. Sorry.
Can you hear me now?
Yeah, we can.
Okay, so well, we're going to go around the table now. I want to thank everyone for participating. Share your thoughts or questions or comments or experience. So Betsy, I'll start with you. Any comments, experience, questions with Bruce at this topic? Take yourself off.
Yeah, I was on mute. Nice job, Bruce. I have a passion for this as well. This topic, it's complicated, and I think it's good that we're having more and more discussions about it. And my hope is that we can really start to influence decision makers about benefit design, whether it's a worksite clinic, it's employer health group coverage, providing perks for employees, but really getting that paradigm to shift to walk in the shoes of the person that you're designing your benefits for. So thank
Thanks
you.
very much.
Scott. You're welcome.
Cindy Jo, comments or questions for the discussion?
I really enjoyed the presentation, and when we're speaking with employers, we're trying to show the value of an on-site or a near-site clinic, and a lot of times it boils down to the bottom line, down to budget, which is understandable. But I think the key to offsetting that is the cost of either not retaining employees or having employees with poor health that aren't at optimum health, and how that then affects the production.
Thanks very much. Laura Spalding, Laura, comments and questions?
No, I just really appreciated the data that you're working on, Bruce, and I've already connected with you on LinkedIn, so I would love to talk some more about what you're seeing in populations as we try to encourage employers to recognize some of the opportunities they have to kind of close these gaps.
Thank you.
Thanks, would be happy to engage, Laura.
Melanie Small, comments, questions?
Just thank you very much. I think it was really well done. And I also think that you made a nice tie between human behavior and the data. And I find that employers are very much into the data, but I think being able to show how that relates to human behavior, which is their employees, is very valuable. So thank you.
Oh, absolutely. My pleasure. Thank you.
Thank you. Todd Hatton, Todd, any comments or questions?
Yeah, Bruce, just to echo everyone else, thank you very much. Very interesting. It would be interesting to kind of take the next step and see, in my eyes, the next step of how federal law and restrictions on how health plans can be set up and what those minimum benefits are, and how much customization can be done based on, as you said, race gets in a really sticky place, socioeconomic class or salary versus hourly status, and see if we can open up the way for equity to become the main conversation in these benefits, not, hey, they're getting more than me, when you're looking at differences in quality.
Yeah, and if I may, just to your point, the 2022 Kaiser Family Foundation survey of employer health plans showed that only 7% of employers offer any kind of wage-based subsidy for employees. We know that number is higher in the jumbo corporations, probably in the 20s, but it's still only in the 20s. And the unfortunate paradox is that low-wage workers have a higher disease burden. They have less healthy lifestyles and more chronic diseases. So we're asking the people who are generally the sickest with the fewest resources to pay more, a bigger share of their earnings toward healthcare.
Right. Yeah, anybody else on the call that I didn't call upon, or anyone else who has any comments or questions? If not, again, let me thank Bruce for the wonderful participation, information, and data that he's got. This has been recorded. We will have the slides and recording available. It'll be sent to all attendees and will be for NAWIC members on our website under our resources section. I'd like to invite everyone to our upcoming 12th annual forum in Indianapolis on August 22nd and 23rd on directions and success factors for on-site, near-site, mobile virtual centers. Hope you can all attend that. There's more information on our website at nawhc.org. With that, thanks everyone. Stay cool. Have a great summer. We'll talk to you soon. Bye-bye.
Thank you.